begin roll call of members of the committee?
Absolutely. Is Jessica Barlow here?
Jessica Barlow here.
David, we can hear your, I'm not quite sure what you got going on over there, but I was like, we can hear you.
There's a YouTube video of our meetings. I did not know that till right now. I only get like a digital copy of text only, but that's, I mean, I didn't know the recordings. I thought they were like on a state website. I get that the link is on the website, but I didn't know we were on YouTube.
Yeah.
That's awesome.
Yes, we post them.
Feel famous-ish now.
You can say you're a YouTube star.
All right, we're about a minute away, but we're gonna give it another 60 seconds or 2 minutes to let all the people that are coming into the meeting to get them admitted and put in the right section of this virtual meeting. All right. It is 10 a.m. on February 13th, 2024. This is Chair of the Advisory Committee for Resilient Nevada, David Sanchez, and I'd like to welcome everyone back. We have not met since August of 2023, and our agenda today is packed with important discussions and updates, and these discussions and updates are aimed at helping direct where the litigation funds from the opioid litigation money that came into the state will be directed and really working to, or we're gonna highlight that we're gonna be working more closely with the Surge Group to help inform the director's office as to how the funds should be spent. So we'll start our meeting with calling this meeting to order. We'll go through on agenda item number 1, and I'll ask Joan to help me with roll call of members and establish quorum. We do have a message from Carissa Loper, who is the vice chair of the committee, that she will be a couple of minutes late. So we will call for her and then check her in once she makes it into the meeting.
Jessica Barlow,
Jessica Barlow, present. Good morning.
Brittany Collins Jefferson, Lenitra Grady, I show Lenitra present on the list. Lenitra, you want to verify you're here?
I think we're having problems with the audio. She shows unmuted, but I cannot hear her when she's speaking. But I see her acknowledging us. So
Okay, thank you. Ryan Gustafson,
Ryan's here.
Dr. Kamyar,
I'm here. Good morning.
and Carissa Loper will be late. Catherine Loudon,
Good morning, I'm here.
Elise Monroy,
Good morning, I'm here.
Darcy Patterson,
Here.
Jamie Ross,
Present.
Pauline Sala,
Present.
David Sanchez,
present.
Ariana Saunders,
Present.
Cornelia Sheehan, Malika Totson, Dr. Carla Wagner,
Present.
Quinny Winbush.
Good morning, present.
Okay, we have quorum.
Great,
And
thank you,
for the
Joan.
record, this
I'm
is
sorry,
Dawn
excuse me.
Really. Brittany Collins Jefferson entered as well.
Awesome. We will get her marked as present. Thank you, Brittany, and thank you, Dawn. So as a reminder, this meeting is a public meeting recorded and held in a compliance with and pursuant to the Nevada Open Meeting Law, NRS 241. And as such, all voting members should leave their cameras on for the duration of the meeting and refrain from entering any information into the chat function of the video platform. So because we had changes from Zoom to here now we're on Teams, we're going to ask that you be mindful to keep your camera on if you're a sitting member of the committee so that we can align best with the open meeting laws. I will now move us forward to, Joan, can you give us a heads up if you see Carissa make it into the meeting or any of the other committee members so that we can add them to our roll call and make sure we get them in attendance?
Yes, thank you.
Thank you, Joan. I'll now move us to agenda item number 2, which is public comment number 1. Public comment, thank you. Sorry about that. I'm supposed to remember to say next slide. Public comment number 1. Public comment will be taken during this agenda item regarding any item appearing on the agenda. To provide public comment telephonically, dial 775-321-6111. When prompted to provide the meeting ID, enter 481-559-024#. Please note, if joining by phone, press *6. I think it's *6 to mute and unmute, and press *9 to raise hand. It might just be 9. In consideration of others who may also wish to provide public comment, please avoid repetition and limit your comments to no more than 3 minutes. No action may be taken on a matter discussed under this item until the matter is included on an agenda as an item on which action may be taken. Do we have anybody interested or available for public comment?
If you're an attendee and you would like to make public comment, please raise your hand and we will unmute you.
Thank you, Dawn. And again, the raise hand function is at the top of the Teams. I don't see anyone. Do we have anyone?
No, we have no hands raised, Chair.
It looks like no one. Do we have anybody on phone, on the phone line that's trying to come in to give? Okay. It looks like we have no one interested or available for public comment number 1. Just gonna double check. I don't want to miss anybody or leave anybody out. All right, it looks good. We're gonna move to agenda item number 3, where we will review and approve minutes from our August 8th, 2023 ACRN meeting. Does anybody have any questions or concerns? Did committee members get a chance to look through the minutes? Anybody have anything on the minutes from our last meeting? All right. Can I get a motion from one of the committee members to approve or review our minutes from our last meeting?
This is Elise. I'll motion to approve the minutes.
Thank you, Elise.
This is Jamie. I'll second.
Thank you, Jamie. I'm so sorry. It's been a few months, but I'm pretty sure. Do we need to vote now to approve, or?
Yes, you need to call for a vote. This is Hina Rasul, Senior Deputy Attorney General.
Thank you. Okay, so now we'll vote on agenda item number 3 to approve the minutes from our last meeting. All in favor of approving the minutes from our last meeting? Can I get an aye, or maybe should we do raise your hand or just aye?
Aye.
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 Aye. Aye.
Virtually, that is a very challenging thing for me, I just gotta say. Do I have anybody opposed to approving the minutes from our last meeting? Can I get any nays or opposition? And then do we have any abstentions from approving our minutes from our last meeting?
This is Ariana. I'm abstaining. I was absent.
Okay, thank you, Ariana. And it looks like the motion to pass and approve the minutes from our last meeting is passed, and we can move forward to the next agenda item. Agenda item number 4, we have Fund for Resilient Nevada update brought to us by Don Yohe from our state team. Don?
Good morning, Chair and members of the committee. My name is Dawn Yohe. I'm a clinical program planner with the Fund for Resilient Nevada. And we are charged with overseeing the opioid litigation funds. I was going to share my screen, but then I realized I didn't want to make everybody dizzy. So I just wanted to refer you to the annual report that the director's office submitted. So I'm just going to kind of walk you guys through it. And if you guys have any questions at the end, I'm happy to answer them if possible. So pursuant to Nevada Revised Statutes 433.734, on or before January 31st of each year, the department shall transmit a report concerning all findings, recommendations made, and money expended pursuant to NRS 433.734 to 433.740 within the Fund for Resilient Nevada. This report, the way we structured it is we had an introduction, which kind of talks about the history of the opioid crisis and where the state is currently. It talks about the needs assessment, how that was developed, the state plan, and then we went into identifying the high priority goals. So just as a reminder, goal 1 in the state plan is to ensure local programs have the capacity to implement recommendations effectively and sustainably. Goal 2 is to prevent the misuse of opioids. Goal 3 is to reduce harm related to opioid use. Goal 4 is to provide behavioral health treatment. Goal 5 is to implement recovery communities across Nevada, really focusing on the social determinants of health. Goal 6 is to provide opioid prevention and treatment consistently across criminal justice and public safety systems. And then goal 7 is to provide high quality and robust data and accessible, timely reporting. We identified some of the findings, went through where Nevada has a very strong foundation of evidence-based treatment services and supports across all current systems of care, including prevention, treatment, and recovery supports. However, opportunities for strengthening the current system also exist across all components of care. Unfortunately, the data has shown that from 2021 to 2022, there was an increase in fatal drug overdoses in Nevada at 6.2%. And so that's something that we need to focus on. And then it kind of flows into a little bit more data. We did talk about the Nevada Silver State Scripts Board, which handles the preferred drug list for management of Nevada Medicaid fee-for-service programs and some of the opioid antagonists that they had approved for funding. We went into the funded programs and projects, and I was just going to list some of these for you guys because I know sometimes it's hard to identify what this fund is making a priority. So goal 1, like we talked about earlier, to ensure local programs have the capacity to implement recommendations effectively and sustainably. We were able to complete a subaward for an opioid training and technical assistance center. This will be a center for excellence. And then also out of this goal, we funded a statewide conference addressing the opioid epidemic, collaborating across the continuum of care, which was pharmacist-centered to really bring the pharmacies on board. We provided seed money for the American Association of Treatment for Opioid Dependence, which is the ATOG conference, which is happening in May. So if anybody can go to that, it's May 18th through the 22nd. And then we're also providing funding to the Nevada Indian Commission for a program position in order to support a position to assist us with identifying gaps and needs among Nevada's tribal communities. Goal 2 was to prevent the misuse of opioids. Currently, we are only funding the multi-tiered systems of support, which is the MTSS project, which is within the schools. And we know that we're going to need to funnel more money into prevention efforts. We did just currently close a youth NOFO, which I will talk about a little bit later. Goal 3 is reduce harm related to opioid use. We are currently funding access to needles with Track B exchange and in order to fill the vending machines throughout the state. And then we also have money set aside for overdose reversal medication, as well as testing strips for fentanyl and xylazine. Goal 4 is to provide behavioral health treatment. We are funding mobile recovery units, which are currently being built, and we're hoping to get those up and running by the spring/summer of 2024, this year. We are braiding in some state opioid response grant money in order to provide the staffing for those mobile units. And then we have identified a need for making sure that pregnant and postpartum women get care that they need, especially in some of our rural areas. So the Empowered program will also be taking one of those vans. We are funding the Empowered program currently for pregnant and postpartum opioid support as an expansion in Clark County. They also have a grant from SAMHSA, which they are going to be expanding up to the northern areas. Opioid and intensive outpatient behavioral health services with Living Free Health. Living Free Health kind of goes between goals 4 and 5. And so we are funding them for treatment as well as transitional housing. And then residential treatment in Carson City and alternative sentencing treatment programs with the Washoe County Department of Alternative Sentencing. This one also straddles a few goals. So this one is in goal 4 for treatment, as well as goal 5 for recovery communities across Nevada. Goal 5, implement recovery communities across Nevada. We talked about those. And then goal 6, provide opioid prevention and treatment consistently across criminal justice and public safety systems. We are working with the Division of Healthcare Financing and Policy to develop a waiver for a 90-day pre-release. It's a 90-day pre-release waiver for those in jails and prisons, and we are providing match in order to lift that waiver. And then we are working with a retired Captain Bill Teal for a Nevada Rural Jail opioid disorder research and implementation project. We'll bring him in as well to give you guys some information about phase 1 and the completion of phase 1 and moving on to phase 2 with that. And then goal 7 is provide high quality and robust data and accessible timely reporting. We were able to purchase some of the handheld mass spectrometers for the counties. We're working with the Division of Emergency Management in order to place those, as well as develop training in order to have public safety throughout the state. And then we have provided match for an all-payer claims database with Nevada Medicaid. And then the Division of Public and Behavioral Health, we are working with their EMS in order to support the ODMAP API. Our recommendations were to continue following along our needs assessment as well as our state plan. We will be starting to look at different gaps throughout the state starting next year, which we'll need your guys' help with in order to start developing the new state plan for 2026. And then in the plan, or in this report, we also attached all of the expenditures for calendar years 2023. I know that was a lot of information for you. We will send you all a link. This report is all on the website at the FRN website, so you can find it there. Is there any questions about the annual report? Okay. Continued activities and, Elise.
I'm so sorry. You know, I'm always good for a couple questions. It took me a minute to get off mute. Okay, Chair, I have 3 questions. Is that okay?
Absolutely.
Okay, excellent. So Dawn, the Opioid Training and Technical Assistance Center, where is that going to sit? Will that sit in HHS or CASAT or like a community-based center?
Yeah, thanks for asking. That actually is going to sit with the University of Nevada, Reno at CASAT.
Okay, excellent. Okay, and then my second question is well, it's not a question, it's just a statement about the handheld mass spectrometers. I was pulling up the report. I don't see that there's a ton of detail under that item because I know you have to work with DEM to get them out. It would be my hope that in working with local law enforcement, that those handheld mass spectrometers would be used for public health surveillance sampling as opposed to prosecution. My concern from a data perspective about giving local law enforcement handheld mass spectrometers is they will be used in the commission of prosecuting people for crimes related to drugs, and that's concerning to me. I would also hope that as these handheld mass spectrometers are being distributed, that there's some sort of data sharing agreement between local law enforcement that takes them and the state. One of the experiences that I had on OD2A was that local law enforcement partners were like happy to say in meetings like this, well, we're happy to share data, we're happy to share information, and just ask. And then I would ask and be told that's part of an active investigation and we can't talk to you about it. Or our role is forensic, not public health, so we can't give you data. So I actually have a lot of heartburn about any money spent on this at all. So I hope that through an MOU or something, it can be assured that they're not used for prosecution and that there's data sharing agreements in place. And you don't have to respond to that, Dawn. It's just a little like me having a comment. And then my last question is related to the like outcome information. So I know that the Attorney General's office is, and you're working really hard with the AG's office to put together the dashboard to report out on where money is going. Is there any way that like outcome data or annual reports from the subrecipients can be put into this public sharing? Because I'd be really curious to see like the actual reach. So, funding for residential treatment. Well, how many people is that supporting? 100, 5, 105 people. So is there any way that we can make outcome data reported publicly? Okay, thank you.
Thanks for your comments, Elise. This is Dawn for the record. In regards to your last comment about making outcome data more accessible, yes, that is our goal, is to make sure that when providers are submitting their reports, we are able to provide that information on our website. We have talked about making our provider reports available and letting them know that any reports that they submit to us on a, whether it's an annual basis, I believe it's an annual basis, that those will also be shared on our website. Same with the One Nevada signatories. We are compiling all of their information currently. So all of the individuals who receive any of the opioid litigation dollars are required to fill out a report, and that information is then compiled into an easier to read type of spreadsheet where it has how much money they received, how much money they expended, how much bankruptcy dollars they expended, their scope of work that they're using in order to use these dollars, what targeted populations they are focusing on, and outcomes that they have seen. So that will also be slow progress, but we are hopeful that that will also be up on our website as well for viewing.
Excellent. Thank you for the information.
You're welcome.
Thank you so much for your questions, Elise, and responses, Dawn. I appreciate that. Do we have anybody else with questions or comments for Dawn?
Great. And so this is Dawn. As we move forward, we're going to be developing a really large NOFO that's hopefully going to go out here in May or June, which will have all of the goals on it. So instead of focusing on one goal at a time, we're going to do a large NOFO that's going to have all of the goals on it so that we can get ready for, the biennium and make sure that we are addressing every single goal appropriately and having funds, moving towards all of these goals simultaneously. And so that's going to be the goal coming up as far as future distribution of funds. We're also going to be developing a flow chart of, if you're a state agency, how do you apply for funds? If you are a private provider, how do you apply for funds? We're going to have kind of a flow chart, which will help alleviate some of the questions that have been coming up recently of, if I'm a county entity, do you have a needs assessment already? Are you working with another county entity? Do they have their needs assessment? So that will alleviate some of the questions, and that will also catwalk back to the legislation. So we're hoping to make that a little bit more transparent for everybody. And then finally, we did release a youth NOFO specifically for youth services and programs. That was released in October of this last year. It closed in December. And then we have identified 4 providers at this time in order to be funded, which include the Boys and Girls Club of Southern Nevada, Lyon County Health and Human Services Agency. My mind is blanking. Nye County Community Coalition, as well as Quest Counseling and Consulting in Reno. And so those are also all on the website with intentions to fund. We are going to be keeping the rest of those applications on file. And as we move forward and pull out additional dollars, we will be looking to fund some more of those providers. Any questions on that?
I have a quick comment or question. I remember in the material submitted, I believe in our 2022 report, there was a portion in there about just making sure that the funds that are going out are being used for what they were meant to be used for and not being wasted. And I think it speaks to the comment that that we heard, oh my goodness, I'm just Elise bringing up earlier about the mass spectrometers, and I think it's been like a constant for this committee to be concerned with the idea of, well, one, it's important that there's a need for these mass spectrometers to be out there, but with that comes the opportunity to be used as like a punitive measure rather than what this committee, made the recommendation for them to be used for. Sorry. And I guess just what I'm looking for is like, where are we at in terms of confirming that the funds that are going out and that the providers that are being receiving funds are being held accountable to make sure that they're being used to benefit the community rather than just be wasted or have negative impacts on the community we're trying to serve.
This is Dawn. I think what you're asking is, have we done any evaluations on the programs that we're currently funding, and if they are beneficial to our communities? We have started pulling data from all of these. You have to remember we only started funding providers in June of last year, so we're not even at a year point. But we have been collecting data from all of our providers. We have been starting some of the evaluation of the data. And then we actually did bring on a biostatistician as well, who's going to be helping us with dashboards in regards to all of these goals, how much money is going out the door, how much impact we are having on the communities. And so that is all stuff that we have high hopes for, that we will be able to share with you guys. I hope I answered your question, Chair.
No, yeah, that definitely makes sense. So over time, we have systems in place that will help us evaluate if this is working, if this is not working, and so on and so forth.
Yes.
Great, thank you. Any other questions or comments for Dawn? Dawn, are you all wrapped up on your section?
I'm all good. Thanks, everyone.
Yes, thank you, Dawn, for bringing forward the information that you did and giving us your presentation. At this time, we will move forward from agenda item number 4 to agenda item number 5, where we have a presentation of substance use response working group. That's the surge. An update from them by Dr. Kearns.
Good morning. Thank you to the ACRN committee members for allowing me to present to you on the surge and our recommendations for this year. I'm just going to get my screen shared so you can see the recommendations as well. Okay, again, Terry Kearns with the Attorney General's Office. My position funded through the DHHS through the State Opioid Response Grant, but sits at the Attorney General's Office and helps with the surge and also the subcommittees. So as I go through this, I just wanted to highlight that this link that you see on this slide is the link to the full surge 2023 annual report. It is a 73-page report. Happily for you all, I'm not going to go through the whole report, but I would direct you to that report so that you can look at some of the items that I'm not going to go into great detail on, but there is an appendix that provides research links that we use to come to our recommendations. There's also more detail on each of the recommendations in terms of the justification and background for the recommendation, the action steps that the surge committee members came up with, and then the impact, capacity, and feasibility of implementation, urgency, and how the recommendation advances racial and health equities. So those specific justifications are on pages 7 through 29 of the surge report. But I first want to put all of the surge recommendations up so that you can see them. I'm not going to go through each of them because as you all know, the surge does focus on all substances, not just opiates. So some of our recommendations are not opiate focused. So I will highlight for you as I go through these, the ones that do focus on opiates and do focus on the expenditure of opioid litigation settlement funds or from the Fund for Resilient Nevada or from other funding sources. And then also any that we came up with that a possible BDR. The surge as the ACRN does not have BDRs, but the Attorney General has some BDRs and we do have some legislators on our committees. And then also, if it's not one that would come from surge or our legislators to support maybe other groups such as the policy boards if they have a recommendation. So I just wanted to highlight that to you all. And as I go through here, again, the ones that I will speak to that do deal with opiates and the expenditure of funds, I'm going to go into more depth. But I did want you to see all of the recommendations that we did come up with. Of the surge recommendations for this year, we did have 18 ranked recommendations and 2 unranked recommendations. I'll talk a little bit more about that. And when you look at our surge annual report, there are the sections, there's executive summary, there's the methodology, and then how we rank the recommendations, the actual recommendations, and then we have 5 appendix. The first is additional information for the recommendations with research links. The second, or Appendix B, is additional information for the recommendations that speaks to which target population the recommendation would address. Appendix C is additional information for recommendations as related to legislation that would be addressed or that has previously been addressed. Appendix 6 is the status of our 2022 recommendations. And then the last one, excuse me, is just information regarding the surge membership the structure and our activities. Again, I'm just going to scroll through these all so that you can see each of them and then go back more in depth to the ones that we think will be of concern for the ACRN. Just a couple more slides on all of the recommendations, and then I'll get to the meat of this. This is the last ranked recommendation that we had. And through the process that we went through this year, I will tell you that what we did is we have the 3 subcommittees, as you know, the prevention, the treatment and recovery, and the response subcommittee. So each of those subcommittees brought their recommendations forward to the entire surge. And then the surge members went through and talked about them. We had some that were very similar, so we tried to collate those that were similar into one recommendation instead of having 2 competing but similar recommendations. And and then after that was all done, that process went back to the surge, and each surge member was to rank 5 recommendations. So that's how we came to which was the first highest ranked recommendation on down through the 18, and then the unranked. We didn't want to not include the unranked, but they will probably get further work on them, but just wanted to include them because they were recommendations that came forward. So now to get to more of the meat of why I'm here to talk to you all is the recommendations that had an action step to expend opioid litigation settlement funds. The first recommendation was to recommend to DHHS, DPBH, the Bureau of Behavioral Health, Wellness and Prevention, to double the amount of investment in SAPTA primary prevention programming, and over the biennium to increase from the current funding of 12 million to 24 million, and that prevention aimed at ages 0 through 24, and then to review that funding allocation annually. And one of the things that the subcommittee really highlighted is this funding should not be at the expense of other existing programs that are already out there. So really on a focus on that primary prevention and increase the amount. And again, I welcome you to go back to the surge, look at the justification, look at the research and all of the information as to why and where they came up with that number. We did have a presentation from DHHS on the funding, the SAPTA funding for primary prevention. And that was where the committee then came up with these numbers that they're looking at for the expanding from 12 to 24 million for the biennium, and then to look at it again annually. Recommendation number 2 was to expand the access to MAT, medication assisted treatment and recovery support for substance use disorder, SUD, limiting the barriers to individuals seeking treatment regardless of their ability to pay, and encourage the use of a hub and spoke model, as well as recovery support, including the use and promotion of telehealth, considering the modifications that have been made under the emergency policies to those X waivers, and then pursuing innovative programs such as establishing Bridge MAT, medication assisted treatment programs in emergency departments. So again, we realize that we have a lot of places throughout the state that don't have ready access to MAT, so wanted to look at it really innovative ways and expend more funding so that people can get access to medication assisted treatment. Recommendation number 6, which is to implement a specialized child welfare service delivery model with follow-up and referral and linkage to care that improves outcomes for children and families affected by parental substance use and child maltreatment and pregnant or birthing persons with substance use disorder. And one of the things that the surge is looking to do is, as with the ACRN, our membership is mandated by the legislation, but we've had the request to add people to our membership, and that would have to be through an amendment. So one of the things that we were looking at doing is bringing someone from child welfare onto the surge who could refer more to this, because our understanding is it has significantly impacted child welfare in terms of either family members who have been incarcerated, family members who've had the children taken because of substance use issues and mental health issues, or that the parents have died from an overdose. So this was really at the genesis of this recommendation. Recommendation number 7, support harm reduction through making a recommendation to DHHS to utilize opioid settlement dollars to designate a baseline level of identification and overdose reversal medication for the next 10 years in our state. Base this on the state naloxone saturation plan that would create a stable, sustainable source of overdose reversal medications through the state. And the surge made a very concerted effort in saying opiate or overdose reversal medications. So it didn't just specifically call out Narcan, but as other medications are approved through FDA, that those could be considered as well. Recommendation number 9 is to evaluate current availability and readiness to provide comprehensive behavioral health services to include, but not limited to, screening, assessment, treatment, recovery support, and transitions for re-entry in local and state carceral facilities. For example, implement follow-up and linkage to care for individuals leaving the justice system. This was an example of one of the recommendations that that 2 committees had come up with separate. So it was combined into one, making sure that to include the language that both of the subcommittees had brought forth. Another part of this recommendation is to recommend the allocation of funding to support the development of the Medicaid Reentry Section 1115 waiver to increase health care for people leaving carceral facilities and to support readiness of carceral facilities to implement the 1115 waiver. And this is the whole topic of basically reinstating or getting Medicare for people who are going to be leaving the carceral settings up to 90 days before they leave those settings. So there will be a smooth transition if they are on medication-assisted treatment, that will continue on, and there will be no gap in those medications or services. And then we also recommended legislation to require the Department of Healthcare financing a policy to apply and implement the 1115 waiver to increase healthcare for people leaving carceral facilities, ensure there's an evaluation of the readiness for planning and implementation. So we really suggested a BDR. Many of the states who already have this, I think last I had heard there were 2, they do have legislation that backs up their state to have the 1115 waiver. Recommendation number 11 was to leverage existing programs and funding to develop outreach response providers and/or personnel that can respond to any suspected overdose or to those who are provided treatment for an overdose in a hospital, emergency room, or by EMS, and offer follow-up support, referrals, and services to the individual and those impacted by the overdose. For example, other persons with a personal and/or emotional connection to the victim, surviving family members, and/or post-mortem services for the families following an overdose. Providers and/or personnel to be deployed to anyone being released from institutional and community settings. And examples of those are hospitals, carceral facilities, and other institutional settings who is being discharged post-overdose or suspected overdose. Ensure this recommendation is included as a build out of Nevada's crisis response system is occurring so that tailored intervention for individuals who have survived a non-fatal overdose is included. So we realize that some of our counties do have some of these types through their most and fast teams, but not all of them do. Other ones have teams that do go out, not most are fast, but similar types of programs. But we wanted to ensure that that is something statewide for people who have experienced a non-fatal overdose, and try to provide them resources, harm reduction resources, and also preventative activities. Recommendation number 12, oh, and I should say too, number 11 was a recommendation that was recommended by 2 separate subcommittees, and it was merged into this one with the wording to include from both of those subcommittees. Recommendation number 12 is to recommend that a compliance study be completed on NRS 259.050 number 3 and 259.053. I'll explain that in just a minute after I give you the second part. Provide adequate funding for medical examiners' offices to include death scene investigations, forensic pathologists, forensic epidemiologists, and toxicology testing to determine specific cause of death. This came about, originally it was to get like an independent medical examiner to speak to cases that are prosecuted. The surge did not like the idea of it just being focused on prosecution. So we reworked this recommendation and had a presentation by Washoe County Chief Medical Examiner, Dr. Knight. And what this came up to, the compliance study on NRS 259.050 is basically saying that there should be a referral to either the Washoe County Medical Examiner's Office or the Clark County Coroner's Office from all of the other counties on suspected deaths from drug-related deaths. So the compliance study would be to see if those deaths are being referred to either the Washoe County Medical Examiner's Office or Clark County for either autopsy and toxicology. And then the 259.053 basically says that whatever the forensic pathologist determines as the cause of death is what goes on the death certificate, as opposed to it being decided something different from, let's say, a coroner in one of the counties that uses Washoe or Clark County. So it would be the forensic pathologist who determines that cause of death, and that should not be changed. So Dr. Knight highlighted that this NRS 259.050 and 0.053 was enacted into law, but we don't know if it's being done. So that's why the compliance study was recommended. And then also Dr. Knight very eloquently highlighted that her office, the mandate of her office and Clark County Coroner's Office is not for prosecution, but it's to determine cause of death. And it's determined cause of death, whomever that customer is, whether that's the family members, number one, whether it is for prosecution or whether it is for public health, so that we can get more detailed information on what's going on. So her request was to include these funded positions so they can get the right cause of death. So that's how this one changed, for having that independent medical examiner to go into court for prosecution. And we really expanded it into what you see here in recommendation number 12. Recommendation number 14 is kind of aside to what I heard Don talk about in the Fund for Resilient Nevada for the funding for the vending machines. It's the partner program of the shipping program that is throughout our state through Track B. And it's harm reduction shipping supplies provide for shipping costs for evidence-based harm reduction supplies such as naloxone, sharps, fentanyl test strips, and for the travel costs for the pickup of used sharp products to be returned for destruction, increase advertising about the shipping program to rural Nevada, and in collaboration with local agencies and through community conversations, establish local support for harm reduction efforts, establish an alternative strategy for harm reduction supply delivery if people can't receive delivery of supplies directly. Recommendation number 15 is to recommend a bill draft request to equalize the peer recovery support specialist so it is equal to or exceeds the community health worker reimbursement, and add on an educational requirement around evidence-based harm reduction to both the peer recovery support specialist and the community health worker certification. Recommendation number, and along with the bill draft request, there was also the funding issue to help to support this. So that's why you see that here. Recommendation number 16, establish priority funding areas to ensure entry into treatment and or recovery, ensure that Black, Latinx, Hispanic, Indigenous, and people of color and LGBTQIA communities are receiving culturally and linguistically appropriate overdose prevention, to include things such as naloxone vending machines and media, drug checking supplies to reduce fatal overdoses among those populations. And again, the funding issue along with that. Recommendation number 17 is to engage individuals with living and lived experience in program design considerations and enhance peer support for underserved populations to be delivered through representatives of underserved communities by increasing the reimbursement rates, implementing train-the-trainer models, and enacting policy changes to address limitations to the use of peers in some settings through strategies that include ensure adequate funding for these priorities, target special populations, increase the reimbursement rates, and offer standalone service provision opportunities. And then the unranked that also had a recommendation for expenditure of opioid settlement funds was to recommend the Nevada System of Higher Education conduct a feasibility study to understand the true cost of implementing a wastewater-based epidemiology in Nevada and its ability to support community response plans. Funding for this study may be available through the Fund for a Resilient Nevada. As many of you probably are aware, the wastewater epidemiology was probably most notably used during COVID. But there we had a presentation from UNLV that they are also doing this to look at drugs in the wastewater system. And so really finding out the feasibility, if this can give us any added direction for some of our community response plans and our prevention and outreach. I will pause here and see if you have any questions in terms of the recommendations related to expenditure of opioid litigation funds before I get into these last recommendations that had an action step of a bill draft request.
Elise?
Is there anybody else that wants to go before me? Okay. I actually just have, I think, one question. So the first recommendation was related to doubling the, I don't know, doubling, but like increasing the state spend on primary prevention. So when I think of primary prevention, and there's other people on this group who are way smarter in prevention than I am, but when I think about primary prevention, I think about youth in schools, and that kind of primary prevention. But we know that in Nevada, most people that are dying by unintentional drug overdose are adults between age, the Souters report says 1 in 4 were between the ages 35 and 44. We also know that, and I'm glad to see there was a recommendation to increase the amount spent on harm reduction, but the recommended allocation from the ACRN for harm reduction in total was kind of just pitiful, like I think $100,000 for the whole state. So when I'm thinking about like a recommendation to increase the spend to primary prevention in a place where we know that most people that are dying are adults, And that the fund for harm reduction, which is an evidence-based strategy we know can prevent deaths. I just want to make sure that we're thinking about funding the whole way, or like in a global way. And then my question is there primary prevention, evidence-based primary prevention strategies for adults? Because I think it would be a missed opportunity to fund for $12 million or $24 million to put that into schools when we know adults are dying.
Not being the expert on prevention, I would go back to our prevention, because this did come from our prevention subcommittee. And we did, like I said, have a presentation on the funding that is being expended currently, and also looking at funding, because we realize that some funding from grants and from other programs does go towards specific things. So I'm sure there probably are evidence-based primary prevention for adults, but not being the expert, I would at least have to go back to our prevention subcommittee, who are the experts, and get back to you with an answer on
that. Jamie, did you have a comment or response to that?
Sure. As someone who works in primary prevention, at least, yes, there are adult based primary prevention. Obviously, if the goal is to prevent folks from ever using drugs, most of what we're working on is youth. So moving on in the upstream, obviously, we are hugely pro harm reduction and preventing overdose deaths. But from a primary prevention, our goal is to turn off the faucet. But yes, to answer your question, there are adult-based primary prevention that are evidence-based and have some really great outcomes.
And Elise, I would just add to that, one of the conversations that I've heard, kind of to Jamie's point, is the prevention is focused on kind of getting to those before they get off the bus or get on the bus, not to the expense of those who are already on the bus, so that we can also, that's why we, really focused on the harm reduction and increasing availability and access and funding for harm reduction for those who are already on the bus. So kind of a two-pronged approach in looking at that.
Awesome. Thank you so much for your responses. Quinny Winbush?
Yes, I just have a quick question on number 2 recommendation in regards to expanding the access to the MAT and recovery and support substance use disorder. When you're talking about limiting, to limit the barriers to individuals seeking treatment, regardless of the ability to pay, do you know what that's going to look like? Are they going to have a sliding fee, be on a sliding scale? Are they going to have a payment plan, or how is that going to look as far as those that don't have the ability to pay, just don't have anything to pay?
Yeah, I don't know the answer to that. That came from our treatment and recovery. So again, I can go back to them and ask. And also, if you look in the report, like I said, those pages 17 through 27 do provide more justification and more background information on it. But the idea, once again, is ability to pay, whether that's, like a fund, using funds from trying to expand Medicaid or using the opioid litigation funds, or what that looks like. I don't know that that was specifically laid out, but Quinny, I would invite you to go to the Surge annual report and look at that background justification.
Okay, thank you very much. Appreciate it.
Thank you for your question, Quinny, and thank you for your response, Dr. Kearns. Jamie?
Thank you. This is more of a question, I guess more of a statement than a question. I think these recommendations are great. Obviously, the Surge makes the recommendation, and then the ACORN, we work on funding. And I'm not seeing a specific tie between these recommendations and the funding. So I'm hopeful that in either later on in this meeting or in future meetings, we will be able to understand how these recommendations will then be funded through the ACORN. Again, not funded, but
funding recommendations made.
Yeah, and a part of it I would defer to Dawn to answer, but what we wanted to do is anytime that the surge did make a recommendation that the opioid litigation funds could be a possible source, that it went to the ACRN, and then once again that collaboration between the surge and the ACRN. I know that as Dawn highlighted in her presentation with the NOFOs that go out, that's one way. And Dawn, I don't know if you have any other comments on other ways that the ACR would implement the funding.
This is Dawn, for the record. Jamie, I think, so really what we wanted to do here was, because the surge was identifying the opioid litigation funds as a potential mechanism to fund some of their recommendations, we wanted to bring those in front of you guys to see if any of these were recommendations you wanted to put in your report to the director's office. So are any of these that something that you're like, yes, I think that's really important, and we as an ACRN want to vote and move that recommendation forward in a future meeting? We're going to then pull all of those recommendations and poll them so that we can prioritize them for you for that report. Does that make sense?
It does. Thank you very much.
Okay, thanks.
Awesome response. Thank you so much, Dawn and Dr. Kearns. I have another hand up, Elise.
Thank you, Chair. So I just wanted to kind of close my thoughts on the primary prevention, and actually the information about the next steps is helpful. It was my understanding that the settlement funds were intended to mitigate the harms of inappropriate prescribing, all of these like bad things that have happened. So these harms in my mind, this money is intended to mitigate the harms for the people on the bus. Like, yes, we want to stop people from getting on the bus, but I think it would be a real great disservice to the people who are on buses careening towards cliffs to say, what a horrible, awful situation to have created. This better not ever happen again. So let's dump $24 million into keeping people off of the bus when there are thousands of people that are careening towards cliffs. So it would be my hope that I do think there needs to be additional state investment into primary prevention. I think $24 million is way too much to focus on youth primary prevention. So it's my hope that we can use data, which tells us 1 in 4 people dying by unintentional overdose is a male adult. I'm hoping that we can use data to drive the actual allocation or recommendation for what that $24 million kind of looks like. So that's all I wanted to say, Terry, this and everyone on the surge, this was, these are really well thought out recommendations. And I look forward to an opportunity to talk about how the surge or the ACORN can recommend funding. I personally think that funding for specialized foster care, funding to support 1115 waivers, those are all things that are going to make needed investments into our system that will help the infrastructure of service delivery outside of opioids, which I think is amazing. But I just want to make sure, and I'm sorry it's like stuck in my craw, but that's a huge investment in primary prevention, huge. And we know that primary prevention historically has gone to prevent youth from using, and that is not the problem. And that is not really, I believe, what this mitigation fund is supposed to be mitigating against. So that's all I have to say, and I appreciate all the work that you guys did to put this together.
Elise, thank you. Your comments are appreciated. And one thing that I would highlight is, again, these were recommendations. Nothing's written in stone. That would be something for the ACRN, as you said, to discuss and debate and come to. But I think that was what the Surge Prevention Subcommittee put out there as a starting point, rather than just say increase funding. Well, increase funding by how much, and that stuff. So I think they wanted to put some more concreteness to the recommendation. And as I said, it's a starting point for you all to discuss and come up with what you see as your recommendation off of this.
Awesome.
I thought I saw another hand.
Me too, but it looks like it disappeared. And thank you, Elise, for bringing that up. And you mentioned what is it? Harm reduction budget that we saw was like $140,000 for each year for the next couple years. And just again, I appreciate Dr. Kearns bringing forward that this is a recommendation and that we can talk about it and help come up with a plan of what it would actually look like as an actionable item, or what's the action to go with it moving forward with Surge's recommendations. Do we have anybody that had a comment or a question? We saw a hand up and looks like it's gone now, so we can move forward if there's nothing, or you can put your hand back up. Oh, there we go. We got Catherine Loudon. Catherine?
Thank you. This is Catherine Loudon for the record. I don't want to not proceed with further discussion about some of the things that you mentioned today, but I would like to remind everyone when we're talking about prevention, we're talking about systems and families and community footprints that the school districts and prevention providers can provide to families comprehensively. And I certainly believe that children have been harmed through a lot of the things that happened related to the purpose of this committee. And so I think preventing them from future use as an impact and an outcome of what occurred, and preventing them from harm related to what has occurred in their family systems and their caregivers needs to continue to be a focus of us as a group.
Absolutely. Thank you, Catherine.
Yeah, thank you for providing that comment based on your background and expertise. And one of the things too, I think as the Surge looked at these, a lot of these programs are supported through grants. So what's going to become your sustainability plan? And I think that was put into the mindset a lot of the subcommittee members as they came up with these recommendations and trying to look at sustainability of programs as well. If there are no other questions, I'll move on to the recommendations that we had with an action step of a bill draft request. Again, I just highlight that the AG does have some, we do have some legislators on our committee, or I have provided the 2023 Surge annual report to the behavioral health policy boards, because I know they also have bill draft requests as well. So the first recommendation is recommendation number 8, support harm reduction through the implementation of changes to recruitment, retention, and compensation of health and behavioral health care workers, and enhance compensation in line with that Commission on Behavioral Health Board's letter to the governor of June 2022. Additionally, continue to sustain and expand investment in community health workers, peer recovery specialists, and my apologies, it cut off, but certified prevention specialists as well. And the certified prevention specialists play into that whole discussion we just had about the primary prevention as well. Recommendation number 9, evaluate current availability and readiness to provide comprehensive behavioral health services to include, but not limited to, screening, assessment, treatment, recovery support, and transitions for reentry in local and state carceral facilities. For example, the implement follow-up and linkage to care for individuals leaving the justice system. That includes that a recommendation of legislation to Division of Healthcare financing a policy for the implementation of the 1115 waiver, which we talked about previously. Recommendation number 10, create a bill draft request. at the legislature to change the Nevada paraphernalia definition as it relates to smoking supplies. And if you look in the report under the justification section, it does show the language because some of our committee members did highlight that it's not just the injection and ingestion of supplies, but there's an increase in smoking of many of the drugs that we're talking about. So that was why the recommendation was to amend language on the paraphernalia definition. Recommendation number 12, recommend that compliance study that we talked about in terms of seeing if the referrals are being made to Washoe or Clark County Coroner's Office on suspected drug overdose deaths, and then also to ensure that the forensic pathologist cause of death is what goes on the death certificate. Recommendation number 18, support harm reduction through create a recommendation to the legislature modeled on Maryland's STOP Act, which authorizes certain emergency medical service providers to dispense naloxone to individuals who receive treatment of a non-fatal drug overdose or were evaluated by a crisis evaluation team and requires certain community services programs, certain private and public entities and hospitals to have a protocol to dispense naloxone to certain individuals free of charge under certain circumstances. So for EMS and police, it would be like the naloxone leave behind programs. For our hospitals, it would be to dispense naloxone. I know some currently are, and there's discussions by some to get vending machines in the emergency departments. So still work to be done on that. But and there's a link for Maryland STOP Act in the research and justification in the report. Once again, I want to provide the link to the surge report to everyone to ensure that you get the opportunity to go and look at it. And if there's any questions on anything to include those bill draft requests, I would entertain those now.
Dr. Wagner? And thank you, Dr. Kearns.
Hi, thanks, Carla Wagner. Terry, just a quick question on that last one. Did the committee, is there a need to revise the law around naloxone distribution? I thought our current law would already facilitate this.
I think the recommendation was some places, for example, will do it, some places won't, some hospitals will. So trying to just maybe codify more and get the ability to do it. I know, for example, there's a hospital here in Clark County that has started dispensing naloxone, and they did it under what they perceived as the ability of pharmacists to prescribe naloxone for somebody leaving. So I think for more standardization and just providing that the STOP Act was provided to us by one of our prevention subcommittee members as an example. So maybe a compare and contrast between the STOP Act and our laws that are in place to see if there's things that they're doing. But I do know based on what I've heard from the state in terms of there are some places that are doing the leave behind program, but there are other places who won't do it. So
yeah, I'm pretty confident. I think it would be worth looking at and maybe getting the LCB involved. I'm pretty confident that the law that was passed in 2015 already authorizes all of this. So if it's about kind of a mandate to make people do it or to compel people to do it, that's a different thing. And part of the struggle sometimes with hospitals and especially emergency rooms, it's not a legal issue, but it's how they dispense drugs and whether they have the systems in place that allow them to dispense outpatient drugs through the emergency room. So it may or may not be a state law issue that needs addressing here to encourage and standardize.
Right, your point's well taken. And I know in doing some research on this, there is another state that got a vending machine in their emergency department, but it wasn't run and refilled and everything by the hospital. It was a community partner who did it. So it kind of did away with any of the, we have to do it this way because it has to go through our pharmacy and because it was run, operated, and the upkeep was done by that community partner, not the hospital, for an example.
And so some of this is a conversation with the pharmacy board and the hospital pharmacists.
Yeah. Thank you for those comments. You're absolutely right on.
Do we have any other questions for Terry before we move forward? All right. Thank you again. And it looks like it's gonna stay your floor, Dr. Kern. So I'll move to agenda item number 6, presentation on high intensity drug trafficking areas, overdose detection mapping application program. And the floor is yours, Dr. Kearns. I don't know if you want a minute of silence so you can catch your breath and drink some water, but
let me get just a drink and then we'll go on.
Absolutely.
Yes, I wanted to just show the committee members the overdose detection mapping and application program that we do have within the state of Nevada. I would highlight to you just a couple of things. This program is for public safety, public health. It's not for members of the just the general public. So kind of you have to have a reason to have access to this data, and but we do run reports for groups so that they can that don't have access to it, so they can use the data that's available in here. I will also highlight that ODMAP is a free program that was offered to any of the states or any localities from the Washington, D.C., Baltimore, HIDA. You heard Don Yohe talk about paying for an API, automated program interface. That's the money part of all of this. And just by way of background, years ago, probably about 2018, 2019, we traveled the state and tried to get voluntary usage of ODMAP from law enforcement or EMS and fire. We let each county decide who that would be. And what I mean by voluntary is that they would have to manually enter suspected overdoses into ODMAP. We had a few places that did, but most did not. And then COVID hit, and pretty much ODMAP got put on the back burner. So what we did is all of this data that you're looking at, and I'll explain to you, is already in the state EMS database. The state EMS database looks at suspected overdoses. They look at other things like response times, respiratory illnesses, all of this other stuff. So, and other states have done this too, where they use this API, automated program interface, that pulls that data from the state EMS database automatically into ODMAP, so no one has to manually do anything. So that's how we came to get the data. It's been in place now for about 2 years where we've been doing this, so we have more robust data that we can use. It's one tool. It is suspected overdoses. They are not confirmed or vetted, but the idea is to get closer to the time of the suspected overdose. When you get confirmed overdoses, such as from the coroners when someone's died, and the information's more vetted, it's typically a longer time. So we were trying to get something in place that was more actionable. When you go into ODMAP, the first thing you see is this national map. You'll notice there are no overdoses in Nevada. One of the problems with our API is that there's a delay in the uploading. So we aren't seeing them in 24 hours, but we would see them within 48 hours. So that's it's a kind of a kink in the system that we're still trying to work out, but we'll continue. So this will show you that based off what's in here for the past 24 hours, you can see in this left lower hand corner the total suspected overdoses, the suspected fatal overdoses, and then the suspected overdoses where naloxone was used. If you look over here, there is a legend that tells you what all these dots and diamonds mean. The diamonds basically are the fatal, and the dots are the non-fatal. So depending on the color, it shows whether naloxone was administered, if it was a single dose or multiple doses, or if it was unknown, the status of naloxone being delivered. So I just wanted to highlight that to you, that that is available. What we can do then is, sorry, I got to get my filter back up. Okay. What we can do so that you can see what's going on in Nevada is you can see there's this filter here. So I would enter our state. Then if we want to look, we'll go this year. We apply those filters and you can start to see what's going on this year in our state. So based on suspected overdoses, there were over 1,116 suspected overdoses. 45 of those were fatal and 385 naloxone was administered. So it starts to give you a picture of what's going on. And then if you want to drill down further, you can pick a county. You can go down to the zip code level within a county if you wanted to do that. And we have run reports going down to the zip code level to look at hotspots. So if we look at Clark County, for example, this year, 766, 28 suspected fatal, and then naloxone was administered in 304 of those cases that we are aware. I'm just trying to get it a little more manageable so it doesn't just look like a big glob. So you can see it gives you a data point on a map, and it really does get down to, you know, a street level view. You can put a heat map on and it will show you where your hot spots are for more of a just a visual look that you can see where those are from that heat map perspective. One of the other things you can do if you go up to this graph will give you that information that you see in those dots and diamonds, but in a graphic form. The first is overdoses by type. So it'll show you what those are, all those dots and diamonds. It shows you, which I think is a really important tool, the day of the week. What day of the week are you seeing the most overdoses? So again, looking at outreach and prevention activities, you might be able to pinpoint better what day of the week and hour of the day. Some of the counties, they were surprised it was a different time of day than what they originally thought their overdoses. So you can see in Clark County, it's midnight, 1 a.m., 5 a.m. are when they're seeing their most overdoses. So again, you can go out on specific days at specific times, and then using the heat map, you could target certain areas as well. Suspected overdoses, you could see, you know, this, for example, on January 26th, it says 30 suspected overdoses. So again, targeting and looking at, and then suspected overdoses per month, we only have 2. This becomes a good tool if you want to go back and look over the 2 years of data that's in ODMAP, especially for a specific county. If you want to see if there's certain months out of the year where you're seeing more overdoses, so maybe you can increase your activities on those specific months, or if it's around certain like special events that are going on as well. I know that the harm reduction activities are increased at those times. And then county state line, this one is interesting. I'm going to change some of these. Oh, before I change that, let me go to this next one. This next graph just shows you all that information we just talked about, but it shows you obviously in a table form. And you can see the majority of these are attributed to the Office of the Attorney General because of that API. Not that we entered them, but it's just that it came over. But then you can see the county, and you can see who it was from, EMS, the date and the time of the incident, and you could go back and look at the record to if you wanted to look up any further information in that. So I just wanted to show you before that. You can clear all of your filters. I want to clear those if they will, and show you that county and state line. So I'm going to show you two here from Nevada and California. We're going to do Washoe County. And then Placer County in California. We'll apply the filters. Go back out so you can see them. For this year, there was only one. You can see in Nevada, so that's not going to show. But what this will show you, if you go to that county or state line, you could enter 2 counties or 2 states, and it would show you graphically the one that happened in Placer, and then if there were any in Washoe, you could see, and you could see if there's trends that they're happening at the same time or not. And this would look at those drug trafficking routes. So I know that the Washington, D.C., Baltimore HIDTA has been using this program for much longer, and they start to look at their trafficking routes. And if they see an overdose, like in this one, you see an overdose in Placer County, and then you spike, you could figure out how long it would take to get into Washoe County, or in their cases, in their areas, and spikes. And they got to the point of some predictive analytics, so that an example they showed was they thought they had a trafficking route from Baltimore into one of their rural communities in Maryland, but they weren't seeing a spike in overdoses in the rural community when they saw them in Baltimore, and vice versa. But what they started to do in looking at their state line and the county is that when they were seeing overdoses in Philadelphia and then following that drug trafficking route down, they were seeing follow-on overdoses in this rural county. So they were able to determine that what they thought that drug trafficking route was from Baltimore into this rural county wasn't what was happening. It was from Philly down into this rural county. And they got to the point where they could see however many hours it was to travel down the I-95 to get from Philly down to this rural county. They could start to predict when they would see spikes in overdoses based on what they were seeing in Philly, and let their partners know, EMS, treatment providers, harm reduction coalitions, and able to get messages out also to people. So it's become a predictive analytic tool that they've used in Washington, D.C. and in Maryland. So that's just kind of a high level view of what you could do. Previously, you had to do all these searches. Now there is a feature in here where you could save a search. So if you're always looking at this one, you could save it, and then it would pull up as a saved search that you could just go to. So always trying to improve and make more user-friendly types of information. I will tell you that some of the reports that we have provided, we've provided to some of the people here in Clark County who do go out and do outreach to people. So they have targeted based on day of week, zip code area, time of day. I know that some of the other counties, the smaller counties, have used ODMAP as a tool, one tool of a data set to look at where they were going to put nalox boxes out in their communities. And also other communities, they were being told that, you know, we don't have an overdose problem in this area. We're going to concentrate all of our overdoses here. And when they ran the numbers in ODMAP and looking at some of the other data they had available to them, they did find out that that secondary area was a high area of overdoses. So we're also able to get outreach and support and harm reduction supplies to that other area. So those are a few of the ways that the data in ODMAP has been used. Again, I do caution, it is suspected overdoses. It is not confirmed overdoses, but one tool in the toolbox that can be used for data that's used with other data sets to kind of give a fuller picture of what's going on. And that is ODMAP. If anyone has any questions, I'm happy to take those. And then you can be done with hearing from me for the day too.
Thank you very much, Dr. Kearns. Do we have any questions or comments for Dr. Kearns after the OD map presentation? All right. Oh, I don't see any hands up.
Thank you all for your time. And if any questions or anything comes up, please feel free to reach out to me. I'm happy to have further discussions on any of this.
Again, thank you, Dr. Kearns. I have not seen the OD maps used in real time like that, and I appreciate the presentation and information. Thank you for showing up today and giving us that. Since there are no questions or comments for Dr. Kearns, we will move forward in our agenda to agenda item number 7, which is recommendations for future agenda items. For this one, I just wanted to give a heads up that we do have a report to the director's office that is due June 30th of this year. We are meant to get this report every even numbered year, and the report is expected to cover the statewide needs assessment. It should include recommendations for the allocation of funds from the Fund for Resilient Nevada, and we will be taking or considering both the recommendations from the Surge and the work that they're doing, as well as our committee's priorities and prioritized recommendations. We will review the statewide plan. We'll highlight the recommendations that we want to see funded in the next 2 years, and we will be prioritizing them. So what I would ask is that you think through what action could be taken along with the highest priority recommendations, very similar to the way that we saw the Surge come up with a recommendation and an actionable item or an action plan along with a recommendation. That's what I'm hoping this committee will be able to achieve in the next 3 to 4 months. So we'll be working closely with the Surge. We got a report from them today, and we'll be keeping them updated on what it is that we're looking towards and what it is that we're doing. This is just to really get a comprehensive recommendation to the director's office. The director's office and the Attorney General's office are working with agencies to develop the media campaigns that we had spoken of as a working group when we were combined. We likely will be not continuing that moving forward, but the work on the media campaigns is still being done through the director's office and through the Attorney General's office. So I guess what I have for you guys here is who do you want to hear from? Is it providers that have received funding and from the Fund for Resilient Nevada and what they have been able to do, or how they've been able to expand services based on the recommendations that the ACRN has put forward, and or are we going to focus more on what it is we would like to see funded over the next 2 years in our report that'll be going to the director's office June 30th. Questions, comments, concerns from the committee members. Now's your time to shine. There we go. Elise and Dr. Wagner.
I'll defer to Dr. Wagner. Go ahead, Carla.
Actually, I was just going to ask you to restate the question. I got a little, I got a little tangled.
Yeah, no worries.
What exactly are you asking from us right now?
So right now it's more discussion than possible action, but what I'm looking for from you is what is it that you want to hear about in our next 4 meetings before June 30th that would help guide our prioritization of recommendations to the director's office?
Okay, then I do have a thing to say.
Okay.
Because I'm listening to this conversation about allocation of funds for harm reduction and I think there were a lot of nice recommendations that came out of the surge for that. I think one of the things that I have trouble understanding is what the capacity is to do that work in the state. I'd like to know more about who is actually out there providing harm reduction services. What are they doing? What capacity do they have to scale? And what are the needs in terms of standing up new infrastructure?
Beautiful. And I think that's what, I mean, in part, that's what I assumed was why we got, why we saw such a relatively amount of funds dedicated to harm reduction in comparison to some of the other sections that we recommended. But it would make sense, right? Is that the infrastructure is not there, that the programming and workforce may not be there as well. So definitely something to look at. And I believe that that is something that I can get the state team to help us kind of bring forward in one of the next coming meetings, as far as if this is an important priority as a recommendation to the director's office from this committee, where are we now and how do we get a more robust harm reduction system within the state? Elise.
Thank you. I agree with Dr. Wagner about harm reduction capacity specifically. I also would like, if we could have a meeting where we look at, and it might be two, I mean, I would like to look at what funding we can do for the surge recommendations. There's a lot of work that went into, a lot of work went into developing those recommendations. And I think some of them are really worthwhile. So I would like to have a meeting to talk about recommending those for funding. I also would like to hear, I mean, I know we only have 4 meetings, but I also would like to hear from the current sub-recipients about what they're doing and also like what's working and what maybe isn't working in terms of like funds going out, reimbursements, things like that, just so we can, if there are changes to be made in regards to how we recommend funding, that would be great. So both things, the surge recommendations and to hear from existing sub-recipients.
Awesome. Good points. And so what I'm envisioning is that it'll be a mix of the two over the next 4 meetings, right? Is that we can start off with a presentation, an update as far as what has been done so far. How did that incoming money from the FRN affect your services? And then after that, the second half of the meeting will set aside for, one of the meetings will be how many of these recommendations from the surge would we as a committee like to push forward? Do we have any questions, concerns, clarifications, edits? I don't know if we're allowed to do edits, but edits that we would like to make to those recommendations. And then the next meeting, the same thing. So we'll hear from a community organization that received funding, what it looks like so far. And then the second half, we'll move to making, getting closer to nailing down our recommendations to the director's office. Carissa Loper.
Thanks, Chair. This is Carissa for the record. For future agenda items, I apologize. I went off camera real quick. I had a call from my doctor's office I had to take. So I just want to make sure that what gets on future agenda items is an agenda item that allows us to work through our recommendations, our funding recommendations that will go on this committee's final report to the director's office, and that we work with our support staff to have a mechanism during the meeting to help us prioritize in real time. That would be discussion based, but I think there are tools and teams that will allow us to maybe rank things individually, that we could see where it falls and then have a discussion based on that if we agree with those rankings. Because I know last last even numbered year, we ran out of time to prioritize, and it'd be nice if we could prioritize this time what our funding recommendations under the Funds for Resilient Nevada are. So that's my broad sort of recommendation for what needs to be on future agenda items.
Yeah, thank you so much. That's brilliant. And really, so if we have the first half report or update as to what has happened so far with the funds from a Resilient Nevada as they've been dispersed, and like Don was saying, it's only been a short amount of time, so getting a complete and comprehensive picture might be difficult, but some type of update from agencies that are ready to would be something that would be looking for. And then during the second half, we'll work on our recommendations, and if we could implement some type of tool through Teams to get that done in a reasonably adequate amount of time, that would be the goal, right? So maybe we don't need to go over all of them in one meeting, but as much as we can get done in the first meeting, go to the second meeting, get as much as we can get done there. And then, we have our list of top 10 prioritized recommendations. And from there, we'll, third and fourth meeting, put them in order the way that we see their importance. Dr. Kearns.
Hi, thank you. I just wanted to add that what was just described was the process that the surge went through, and we had a tool real time that the members voted on. And like I said, each member could vote on their top 5 of all of the recommendations. And then it did prioritize them based on, how many people had it as their top, voted on it. That's why we had the 2 unranked. So I'm happy to connect the staff with the people who we had do that for us, if that helps.
Yes, thank you so much, Dr. Kearns. That's exactly, I think, what we're looking at so far. Do we have any other committee members that have not spoken yet or that we have not heard from recently that would like to chime in on anything they'd like to see as far as future agenda items or any feedback on what we've discussed so far for future agenda items and the plan moving forward to get our report done by June 30th? Any confusion that needs clarification from any of the committee members as far as what we'll be doing in our next couple of meetings? Okay. I'm getting crickets. I'm not going to call anybody out. It sounds like the information that we did get in the discussion that we did have does give us direction for what it is we'll have on our next couple of agendas for our next meetings. And I appreciate those that were able to contribute, and those that were not, thank you for the silent tacit agreement. I appreciate knowing that what I'm taking it as is that we're on the same page and we're moving forward. That being said, I don't think I have anything else for this agenda item. I'm pretty sure we're good. And I'm going to move us I did have a reminder that the state receives a portion of the funds from the litigation money that's coming into the state, and it's to be spent over the next 18 to 20 years. So what we've done so far is, 2 years recommendations to the director's office to get that money to the community, but this will be a continuous process. So where we see that there are gaps or that there are important areas that we would like to target for support and growth, we can keep that in mind and push it along as we move through this 2 years and then the following 2 years and so on. All right, I'm going to move us forward to agenda item number 8 if I have no further questions or comments. Agenda item number 8 is public comment number 2. Public comment will be taken during this agenda item regarding any item appearing on the agenda, and this is to provide public comment. To provide public comment telephonically, dial 775-321-6111. When prompted to provide the meeting ID, enter 481-559-024#. In consideration of others who may also wish to provide public comment, please avoid repetition and limit your comments to no more than 3 minutes. No action may be taken on a matter discussed under this item until the matter is included on an agenda as an item on which action may be taken. Do we have anyone interested in speaking to public comment number 2? If you're in this virtual meeting, please raise your hand. If you're on the phone, please press the buttons that are the right buttons. I have a hand up from Morgan. I don't want to mess it up. Morgan?
Hi, my name is Morgan Biaselli. I'm with Silver State Government Relations. I'd like to thank the Acorns and Surge for all of the hard work that you guys do. I'm here representing the Nevada Opioid Treatment Association. We'd love to have an opportunity to present. We have altogether 15 opioid treatment facilities throughout Nevada. And so I would love to be in contact with you guys to see if we can be one of the presenters in harm reduction in Nevada. Thank you for your guys' time.
Great. Thank you, Morgan, for speaking up and speaking to public comment. Definitely will be included in the minutes and it'll be something for the committee to consider. I have Ryan Hamilton with his hand up. Oh, it looked like you came off mute for a second, but it looks like you're back on mute. I'm gonna try to. No, I don't think I can do anything. Joan or Dawn, can I get?
I think, am I good? Can you hear me now?
Gotcha.
Perfect. I just wanted to emphasize the remarks by the committee member about the majority of the funds going to treatment and people who are currently on the bus. I just think that it should be a priority to help people who are currently opioid addicted, as opposed to some of the other efforts of the committee, which are admirable. But the reality of the situation is that we have more than enough demand for people who are currently in need of treatment. And I think that the emphasis should be on providing treatment for people who are, as she eloquently put, currently on the bus. That's all. Thank you.
Thank you, Ryan, for bringing that forward, speaking as part of public comment. Super important, and I'm glad that you said it. Do we have anybody else interested in public comment? And Joan, can we get a confirmation that we have no one on the phone that I'm missing out on? All right, it looks like I got a message that says there's no one on the phone interested in public comment, and I see no other hands up. I'm gonna give it just a quick second to make sure I'm not missing anybody for public comment, and then I'm going to move to the next agenda item. All right, I'm going to close agenda item number 8 and move us to agenda item number 9, which is adjournment. And as we depart this meeting, I just want to say thank you for all participating. Thank you for our presenters and Dr. Kearns for going the extra mile and speaking on 2 of our agenda items today. Really appreciate your time and effort. And you will get an email after this meeting posting our next scheduled meeting. And again, we do need to meet quorum to continue these meetings as a committee and 1, hear our presenters, and 2, get further along in making our recommendations. So I please ask that you do what you can to attend the next meeting. We are now in adjournment. Thank you for being here.
Thank you.